Welcome to the Louisiana AAP's Fighting Antimicrobial Resistance in Pediatrics webinar. This webinar is supported through a national partnership between CDC's Project First Line, the National AAP, and AAP state chapters. Dr. Patricia Pichilingue-Reto is the Louisiana AAP Ambassador for Project First Line.
Thank you. So, hi, everybody. I'm Patricia Pichilingue-Reto. I work at LSU in Shreveport. I'm an assistant professor of pediatrics, and I do pediatric infectious diseases. So the topic to be discussed today is fighting antimicrobial resistance in pediatrics. We have the following objectives for this activity. We will name some of the infections that are considered antibiotic-resistant threats in the U.S. as per CDC reports, especially those that can affect pediatric patients. We will describe the principles of antimicrobial stewardship programs in pediatrics and how they correlate with infection and prevention control interventions. And finally, we will describe the best strategies to apply antimicrobial stewardship principles when managing special patient populations like neonates or immunocompromised children. So we know that antibiotic overuse puts patients at risk for a lot of adverse side effects, but also this contributes to global antimicrobial resistance. More than 2.8 million antibiotic-resistant infections occurs in the U.S. Every year, and more than 35,000 people died due to these resistant infections every year. Over 65 million antibiotics are prescribed to children in ambulatory settings in the U.S. every year. And according to CDC data, we know that more than half of the antibiotic prescriptions for selected events in hospitals was not consistent with recommended guidelines. We see that there is a lot of antibiotic prescriptions that are not supported when they are prescribed for community-acquired pneumonia, UTIs, also when we see fluoroquinolone treatment prescriptions, or even IV antibiotics like IV vancomycin. So those prescriptions are not supported by guidelines, and it's essential that hospital prescribers and pharmacies help in improving prescribing practices with several goals, including optimizing antibiotic selection, reassessing the antibiotic treatments when we have results of diagnostic testing, and try to use the shortest but the most effective duration of therapy. So it's very well established that COVID-19 affected the antimicrobial resistance, not only in the US, but worldwide. During the COVID-19 pandemic, the detection and reporting of antimicrobial resistant data slowed down tremendously because of a lot of challenges in patient care, lab supply, staff challenges. So everything was actually slow, and we have underreporting of infection prevention and control practices. We know that there was a national shortage of PPE. There was also a national shortage of cleaning equipment, hand hygiene. Everything was out of stock due to the pandemic. And while we know the antibiotics use through the pandemic was very variable across healthcare settings, antibiotics, including macrolides, were commonly prescribed to patients for COVID-19, even though we know that antibiotics don't work for viral infections. So in the US, these are 6 out of the 18 most alarming antimicrobial resistant threats, and this can actually imply a cost of close to $5 billion annually in the US. What I tried to show here are some of the threats that are actually affecting our patients. So we see increasing rates of MRSA infections in children that are community-acquired, not hospital-acquired infections, but community-acquired MRSA. And also, we are seeing greater rates of community-acquired ESBL enterobacteria infections, especially UTIs, patients that have been exposed to multiple antibiotics before, and they develop UTIs due to ESBL, E. coli, for example. So I'm trying to present here some of the reports that are more impactful for pediatrics. So strep pneumo, we have an increase of drug-resistant strep pneumo isolates. So here we see that on this graph, that the CDC has reported that there has been an increase of strep pneumo to selective antibiotics. And this can go up to 40% in some cases, which is alarming. And one of the antimicrobials that have shown to be getting more resistance to strep pneumo can be antibiotics like ceftriaxone. So you may have seen some patients in your practice where patients show a Streptococcus pneumonia isolate that was resistant already to ceftriaxone. Hopefully, the penicillin resistance is actually stable, maybe not getting bad. And something that is also alarming is the resistance to macrolides, including erythromycin. So I will say erythromycin is not a good drug, or azithromycin is not a good drug for strep pneumo because we see greater rates of resistance to macrolides and strep pneumo infections. And we know that there has been a lot of reports of more invasive infections due to strep pneumo. So it's very important that we are also aware. One of the not only stewardship in antimicrobial use for strep pneumo infections, but also we need to promote vaccinations. We now have more updated recommendations about streptococcal vaccines. So that's a way to prevent more streptococcal infections. Also, regarding group A strep, the CDC reported that there is an increase on clindamycin resistance and also erythromycin resistance. Up to close to 25% of the isolates can be resistant to these antibiotics as of 2020. So it's actually very important to know that when you have a patient in the outpatient setting and you diagnose them with a strep throat, consider not using clindamycin or macrolides because these drugs can be not active against group A strep. I think in general, we know that it's very well established that during the past year or so, we have seen more invasive infections due to group A strep. So it's always important to be cognizant that essentially penicillin is the drug of choice for group A strep. So try to avoid all these agents that are actually not showing promising results in regards to resistance. And GBS, which is an organism that also affects pregnancy, but also our patients during the newborn and infancy period. We know that there is an increasing rates of clindamycin resistance. So in patients that have a severe penicillin allergy, it's actually important to try in pregnant females, it's actually important to see if the isolate is sensitive to clindamycin. If they're not able to use penicillin, the drug of choice for GBS is still penicillin or ampicillin. I would say that maybe consider other alternatives like vancomycin if you are not able to have sensitivity reports against clindamycin. It's still very important to continue screening all pregnant women and trying to improve the antibiotic prescribing practices. So what is antimicrobial stewardship? So in 2007, the Infectious Diseases Society of America, along with the American Academy of Pediatrics and other associations and organizations, implemented the core elements to establish antimicrobial stewardship committees, especially in the inpatient hospital setting. So antimicrobial stewardship is a set of practices that were well described by Joseph and Rodolph when they mentioned the 4 Ds of optimal antimicrobial therapy. So the 4 Ds imply to help getting the right dose, the right drug, the right dose, the escalation to pathogen-directed therapy, and right duration of therapy. So essentially, you could use a broad spectrum antibiotic to treat any infection, but you need to choose the one that has the minimal activity against the infection that you're going to treat. It's also important that even though you're able to treat, for example, a pneumonia for 10 days, that's not the optimal duration. You need to have the minimal duration that is effective against a clinical infection. So regarding the core elements for hospital antibiotic stewardship programs, most of you guys here work at a hospital institution that has already a stewardship committee in place because this is a requirement by the CDC. Every single hospital needs to have a stewardship committee in place. I think in Louisiana, up to 80 to 85% of the hospitals have these committees. It's important that you have several things to support starting a stewardship program. You need hospital leadership commitment. You need leaders to appoint leaders for essentially physicians and pharmacists are essential part of these committees. It's pharmacy expertise. It's very important. There's some stewardship programs in hospitals that are totally run by ID or clinical pharmacists. It's important that you plan action and also track how do you monitor antibiotic use in the inpatient hospital setting. It's important to report, but also part of these committees and programs commit to also educate prescribers, pharmacists, nurses, and if you're in a place where there's resident or student training, you also need to educate them on best practices to prescribe antimicrobials. So more recently, the CDC also developed core elements for outpatient antibiotic stewardship. And that can be more challenging because it's kind of, stewardship members don't want to be intrusive in the outpatient setting, but at the same time, I think outpatient antibiotic stewardship can help providers, follow guidelines to be very rational when they use antibiotics in the outpatient setting, keeping in mind that most of the infections that children are going to have are going to be viruses, right? So we have to be cognizant when to prescribe antibiotics. So it requires a lot of commitment, requires also implementing action for policy and practice. It's a lot of help with some either PITS ID providers or pharmacies in regards of order sets or guidelines or clinical algorithms. So they know what to prescribe depending on the indication. They need to know and be educated in regards of what is a first line treatment for community acquired pneumonia or UTI in the outpatient setting. So I think when you have this kind of education from experts, it's easier to help the outpatient providers on how to be rational prescribing antibiotics. So something that is also very important to discuss, it's an stewardship intervention, which is called handshake stewardship. So this is like kind of clinical rounds for the antimicrobial stewardship committees. So what you do is try to discuss in person with providers regarding the antibiotic choices that they are making. So some of the publications that have actually studied the perception of providers in regards of handshake stewardship is that actually they consider that it's a very nice intervention because they feel that they are not being judged. They feel that it's a good non-judgmental environment. They feel that it's a learning opportunity where they can have a chance to be educated on the best way to prescribe antimicrobials. I think also this is a very, very nourishing clinical decision-making, discussion, so they can discuss the the pros and cons of prescribing broad spectrum versus narrow spectrum antibiotics. I think that as part of my training, it was really interesting to have these handshake stewardship discussions with providers in the intensive care unit, either the pediatric ICU, the cardiac ICU, or neonatal ICU. Because at the same time, the physician actually perceives that you are interested in the benefit of the patient. So I think this kind of intervention for stewardship is really important. So hospitals should try to follow this method of interventions. Also for the outpatient or ambulatory pediatric setting, there are several interventions that can be done. One of them is actually being proactive, providing education to patients and parents about antibiotic indications and risk. So CDC has a lot of flyers that can be posted in, in your clinic, where you mention that the treatment for a viral infection is essentially supportive treatment. There's flyers that advocate for not using antibiotics for viral infections. So there are several materials that you can actually share with families or parents, so they are educated about how we protect children for using antibiotics when they don't need antibiotics. Also, there are some interventions that also imply that educators, including, for example, somebody like me, like a pediatric infectious diseases doctor, can try to help with clinical decision support tools or order sets, so they know what, when they have a proper diagnosis of, for example, the strep pharyngitis or acute otitis media or sinusitis or community pneumonia, what is the first line agent to be given for these scenarios. So here you can also say that you can also try to promote, in some cases, delay prescribing of antibiotics, for example, for otitis media, which is justified. And we know that as publications has been done, but also we need to try to also require justification from providers when they are prescribing antibiotics of guidelines. So then you have to explain your rationale when you are prescribing an antimicrobial and it's not a first-line agent or an indicated agent, you need to justify why you are prescribing this. And also, it also implies that there is a commitment letter, and it's actually better to have metrics of the antimicrobial prescribing practices before interventions and after interventions, so you can provide individualized feedback to the clinicians, for example, saying that, before the education, they were prescribing more antibiotics, but after the education or the order sets were implemented in their electronic and medical records, then they were prescribing less antibiotics or less broad spectrum antibiotics. So those interventions can actually have an impact and be measured. Also, I think this flow chart that I found on this website was really interesting. I see that in can be challenging in the outpatient setting when general pediatricians are they are demanding. There are parents that are demanding to get antibiotics, even though you know that a patient has an upper respiratory viral infection. So essentially, when you see a patient that has runny nose, cough, very evident signs of a viral illness, I think that you don't need to do any testing for any viruses because it's very obvious that a patient has a cold. Nowadays, we know that there's also testing for COVID-19 and influenza. So I think I would advocate, especially during the winter season, to test for those. And in some cases, when there are signs or symptoms that are not totally consistent with URI, and if there is ongoing fevers for greater than 3 days or so, you can consider doing some viral testing. But in some cases, it's challenging when you don't have a focus, when you don't know if the patient has a UTI. You can actually, I will say that if I have a patient that has prolonged fevers and there is no other symptoms and no viral symptoms at all, I do support doing a UA to rule out a UTI. And it's also important that you have a very detailed physical examination to rule out on the other entities, including otitis media, for example, in younger babies. So this publication actually mentions, they actually report the impact of antibiotic stewardship programs on the antibiotic choice, dosing, and duration in pediatric urgent cares, which is actually very important to know that there's a lot of overprescription of antibiotics in urgent cares. So they have seen that before the intervention, there was errors in antibiotic choice, dose, and duration in more than 20% of the prescriptions that they analyzed in these pediatric urgent cares. And then they try to assess the appropriateness of these antibiotics, including all these entities like otitis media, strep throat, pneumonia, UTI. So they implemented all these core elements on these pediatric urgent cares. They did some education. They track and report whatever they were prescribing before and after the education sessions. So it was actually really promising. They showed that there was an increase in appropriate duration of the antibiotics from 63 to 80%. There was an increase in the appropriate dosing that they used from 64 to 77% of the prescriptions. And they also increased the appropriate antibiotic choice from 78 to 80, almost 81%. So essentially, these interventions had a positive influence on prescribing behaviors in these pediatric urgent care units. So this is an example from CDC where I think that it's also important to know that apart from antimicrobial stewardship, we are also having more and more knowledge about diagnostic stewardship, which actually implies using the correct test at the correct patient setting, at the correct patient age or scenario. So, for example, for group A strep, for strep throat pharyngitis, we know that testing in general is not indicated in children less than 3 years, and that is part of diagnostic stewardship. We shouldn't be using rapid strep testing for children that are younger than 3 years because 50% or more of them can be colonized with group A strep. So it's actually not indicated to use this testing in these children. And CDC has nice guidelines in how to, what are the first line ages for streptococcal pharyngitis. And if they have any allergies, they give you other options as well. So we know that preventing infections in general is one of the greatest tools to combat antimicrobial resistance. So we need to be aware that we can fight antimicrobial resistance with infection control. So this implies that we want to prevent the acquisition of resistant infections because this is going to be impacting also antimicrobial resistance. So as a frontline healthcare worker, you play important roles in fighting antimicrobial resistance. When you practice infection control, you stop resistant germs from entering your body, from spreading to people, from moving between patients, and from spreading these resistant organisms into the community. So I think antimicrobial stewardship programs and infection prevention control programs have the same goals in regards of, preventing hospital-acquired infections, which usually implied the infections due to resistant organisms. So this actually impacts antimicrobial resistance overall. So it's very important that you know that infection control has a lot of impact on antimicrobial resistance. And I think some of the most controversial interventions for stewardship can be seen in the pediatric intensive care unit or in the NICU. So you have unique challenges here for for antimicrobial stewardship approaches, because in the pediatric ICU or in the neonatal ICU, providers want to always treat patients with broad spectrum antibiotics because they consider that the patients are super sick. But it's very important to have a proper risk stratification. For example, when are you concerned about a patient having a resistant gram-negative? I will say that if they have any history of MDROs, or if they have any chronic disease, or if they have ET tubes, or they have ventilator, or they have contact with healthcare workers at home, or if they have been exposed to a lot of antibiotics or prophylactic antibiotics. So otherwise, it's also important that if a patient has been in the hospital and been receiving third-generation cephalosporins in the previous month, or if they have catheters in place, including a folate catheter, or if they have been in the ICU for more than 48 hours, they have increased risk for hospital-acquired MDROs. And essentially, in regards of the NICU, I think there's some reported risk factors for MRSA infections in the NICU that everybody should be aware of, including a gestational age less than 32 weeks, birth weight less than 1.5 kilos, previous exposures to vancomycin or carbapenems, and obviously being born outside the NICU. So other patient population that can be very challenging as well are the stem cell transplant or bone marrow transplant oncology patients, cancer patients. So in these settings, it's really important to have a multidisciplinary approach. So an antibiotic steward has to be working very closely with not only the oncology provider, but also the parent or caregiver. And also it's very important to work with pharmacy, because these patients are on chemotherapy or immunosuppressive agents that can have a lot of interactions with antimicrobials. It's also very important to be aware of the previous infections, being in contact with microbiology when we find any resistant infection in this patient population, who are by baseline, patients with cancer and bone marrow transplant can receive prophylactic antimicrobials. It's very important that we are aware that the risk for resistant infections it's greater in this patient population. So we have a lot of educational resources everywhere, I will say. So the CDC has this very nice CDC training stewardship toolkit, which is free to access. Everybody can actually go here and get CDC training on antimicrobial stewardship. It's not specific for IT providers or pharmacies. Anybody can take this training. And also there's these patient and physician simulations where which show how to use or how to prescribe or not prescribe antibiotics in the primary care setting. So in summary, your take-home points includes, we know that handshake stewardship is an effective antimicrobial stewardship strategy, which can be very beneficial for the interaction of the stewardship team with the medical providers. Metrics to determine success need to be tailored for children. So we need to have metrics and numbers related to pediatric patients and pediatric patients' use of antimicrobials in the hospital or outpatient setting. Pediatric tools for training are available and recommended. The core elements can be used to develop a framework for antimicrobial stewardship in pediatrics. But it's also very important to know that a wide range of stakeholders is required for success for these programs. I don't know if there's any questions, but thank you for the opportunity to participate in this webinar.